The broadcast is now starting. All attendees are in listen-only mode.
Good morning and welcome to today's NCPDP webinar, Specialty Pharmacy Overview. You can ask a question at any time during the webinar by typing in the question pane on your GoToWebinar toolbar. All questions will be addressed at the conclusion of the webinar as time permits. After the webinar, you will receive an email with a PDF copy of the slides. Our speakers today will be Pooja Babbrah, Practice Lead for PBM Services for Point of Care Partners, Julie Hessick, Director of Clinical and Regulatory Affairs for CoverMyMeds, and Laura Topor, President of Granada Health. I will now turn the presentation over to Pooja.
Great, thank you, Brian. Well, welcome everyone, and thank you for joining us for today's webinar. And I know I speak for my fellow co-chairs when I say that we're really excited to be leading this webinar, but we're actually thrilled to be leading this new NCPDP specialty work group. As you can tell, we've been in the industry long enough to know that this is really an area that's ripe for automation, and it's always great to be involved with any efforts that'll help patients get on therapy faster. So before we jump into the presentation, I'd just like to quickly review the learning objectives we have set for this webinar. So our goal is that by the end of the webinar, you'll be able to describe the NCPDP and electronic standards, explain the current specialty process flows and the burdens to stakeholders, review the current electronic transactions available that are impacting specialty, discuss the goals of this new specialty work group and the task groups that are formed underneath the work group, and especially important, learn how to get involved with the specialty work that we're doing today. And just so everyone knows, next slide, Brian. You can get CE credit for this, and so there is information on your screen and will be in the deck that is sent to you afterwards on how to get your CE credit for this webinar. Next slide. So briefly, here's our agenda. I will be actually providing a brief overview and background of NCPDP for those of you who may not know the organization. And then I'm going to turn it over to Julie, who's going to be discussing how we're viewing specialty in the context of the Workgroup 18 work group, and review some of the process flows around specialty e-prescribing. And then Laura's going to be covering some more specifics around the current NCPDP transactions, which help the specialty prescribing process. And then, as I mentioned, we're going to wrap it up by reviewing how you can get involved with what we're doing. Next slide. So just real quickly, we do have some pre-test questions, and these are going to be the questions that are asked at the end of the webinar. The first one is, what is NCPDP? The second is, what are the existing NCPDP transactions currently impacting the specialty process? And number three, how can you get involved? All right, so let's get into the overview of NCPDP. So for those of you that may not know the organization, NCPDP is actually an ANSI-accredited standards development organization, which is really focused on the standards related to healthcare and especially the pharmacy business solutions. Now, NCPDP is a member-driven organization, and a number of the standards that have been created have been named in government regulations and policies, including HIPAA and the Medicare Modernization Act, which is really the legislation that moved e-prescribing to the next level by mandating e-prescribing for Medicare Part D plans. So NCPDP has been part of the e-prescribing and pharmacy related landscape for many years. Next slide. NCPDP's vision is really to lead the industry in the healthcare standards and solutions, focused on the common good, and also focused on standardizing the exchange of healthcare information, really to improve patient outcomes. And you can see how the focus on specialty prescribing falls into this bucket. We all know how long it takes for patients to get on their specialty medication, and really the focus of this work group, the new work group that is created, is to really focus on shortening that time and to helping patients get on their therapy faster. NCPDP's core values includes collaboration, inclusiveness, integrity, and ethical behavior, leadership, and innovation. And a little bit later in the presentation, we'll be talking about one of the new task groups that was created, which is really focused on reaching out to organizations who may not have been involved before. As you can see, that collaboration and inclusiveness across the industry is one of the core values for NCPDP. Next slide. And finally, we just wanted to share some of the key milestones over the years. So NCPDP as an organization actually celebrated its 40th anniversary last year. And you can see from this key milestones chart all of the great work that the organization's members have been doing all these years, including, as I mentioned, having standards and transactions named in key legislation, the development of a foundation arm, and what they do is they help fund research and education that helps advance the organization's missions. And they also have created strategic partnerships and alliances, including a recent one with Experian Health, to help provide a solution for universal patient ID, which we all know is a huge issue in our industry. So you can see this organization has a lot of rich history, and we're now going to be making even greater progress and helping to lead and set the standards around specialty medications and specialty e-prescribing. So let's go ahead and dive into some of the details, and I'll now turn the call over to my colleague, Julie Hessick, to explain more. Julie?
Thank you. Next slide, please. And then you can go one more slide, too. So what is specialty? I think this is a question that we have all been asked, and there are several ways to answer it. The industry has yet to create one definition for a specialty medication. For 2017, CMS defined a specialty medication as a drug which costs more than $670 per month. These specialty medications can be small molecules or complex biologics. Some actually may define them by their therapies, medications that can treat complicated conditions like hepatitis, cancer, blood disorders, and autoimmune conditions. They can also treat some common chronic diseases like asthma and rheumatoid arthritis. Of course, we all know that these medications commonly require special handling and dispensing. They can be self-administered by a patient or required administration by infusion in a hospital or a physician's office. These medications normally require clinical monitoring of the patient, as well as special training and adherence assistance. They also can be medications that are limited distribution drugs, which means they are contracted to only be dispensed at certain pharmacies. And we can all get dispensing medications or specialty medications from a couple of ways to dispense, from a specialty pharmacy, a hub, a retail pharmacy, or in your physician office. Next slide. So let's take a minute to look at the specialty trends. So as you can see on the left, the balancing of the medication spending is strongly shifting from the traditional to the specialty medications, and this is continuing over the next several years. Of the 42 new medications that were launched in 2017, 32 of these medications were for specialty treatments. Next slide. As you saw on the previous slide, the overall drug spend is increasing. However, if you look on the left, only 2% of the prescriptions are specialty medications that are written. By the year 2021, 50% of the U.S. prescription drug revenue is expected to be specialty medications. Currently, we're seeing about 6 of the top drugs are specialty, and we envision this growing to be up to 9 out of the top 10 by the year 2020. So these include Humira, Revlimid, Remicade, Enbrel, and Harvoni. Next slide. So last year, growth in the specialty drugs outpaced the traditional drugs, and it's 43% of the drug's total spend. We can see here on the right that the specialty spending grew by 9.4%, where we actually saw a decrease by 4% on the traditional spend that was done. Next slide. So now we want to take a minute to focus on the patient journey. When a patient is diagnosed with a potentially life-threatening disease, their life changes. They have a lot of questions, some of them that we've listed here on the slide. Helping these patients begin therapy as soon as possible and stay on therapy is critical. A lot of these patients will feel lost and alone. Most patients don't know where to begin, and they have no idea which pharmacy can fill their prescription. These medications have high copays, likely have prior authorizations, and there is even questions if the medication is going to be covered. If the medication is infused by a hospital or a physician, they may possibly need to miss work or need transportation to get this done. If a patient will be self-administering a medication, they're going to need to be educated on how to do this in dealing with the possible side effects. Unlike a patient's experience at a retail pharmacy, where they actually tell the doctor where they would like the prescription to be filled, the patient on the specialty side has no visibility initially on where this prescription can get filled and how long it will take to begin therapy. We all likely have been to a doctor and started on an antibiotic within probably hours of leaving that physician's office. As we interview these specialty patients, we're seeing that it takes weeks to even months to begin them on their therapy for their medication. And recently we were at a conference where a patient said it took up to 7 months once they got diagnosed to actually receive this medication. So our hope and our goal with Work Group 18 is really to focus and to improve this patient journey by increasing the visibility and improve the speed to therapy for these patients. So let's switch over to the next slide and discuss some of the paths to begin the process for a specialty medication to be dispensed. So we realize that there are several paths. So if you look, the top path that we have is when a specialty patient is seen, they prescribe a medication and it goes to a hub to start the process. On the bottom side, you will see a specialty patient is prescribed a medication and it goes to buy and bill. So where a physician will purchase the medication and to submit a claim for reimbursement of the drug and also the professional service. Where we're going to spend time today is that green path that we have highlighted. So you have a specialty patient, prescribed the medication, and they're sending it to the specialty pharmacy. And this can be by phone, fax, or ePrescribing. Next slide. So I know there's a lot of processes on this slide that we're showing you right now, but our goal here was really to outline all of the process that a specialty pharmacy goes through to dispense a medication. I know that they may vary slightly depending on the medication and on the specialty pharmacy workflow, but we wanted to capture all of the different processes. We also have them color-coded. So if it is in the pink, it is an electronic transaction that has either been created or that we're working on. If it is in that orange color, it is a manual process, so it's still being done by fax or phone. So let's start up top at the left, where you have an incoming referral. The first part of it, and again, these processes may depend on the order, depending on the pharmacy and the medication, is the pharmacy really looking at if they can fill the prescription. Is it a limited distribution? Is this patient in their network? And if not, they'll have to go back to the provider to let them know that. You're also going to receive an enrollment or a referral form. If that is complete, they can continue down the process. If it is not complete, they'll need to go back out again to reach out to the provider. You can see these processes are in orange, so they're very manual, fax and phone-based processes. The next is receiving the prescription. That is in pink. There is an electronic process. Laura will talk about it a little bit later on ePrescribing. We are building out the ePrescribing for specialty medications. When you get to the top right and go down, you're going to see the benefit verification and insurance verification process. So here's where there's really a split. Is this specialty medication covered under the patient's medical benefit, or is it covered under the pharmacy benefit? Typically in the past, we've seen if a medication is infused or administered at the doctor's office, it will be covered under the medical benefit. If it is self-administered by the patient or an oral tablet, it may be covered under the pharmacy benefit. The pharmacy benefit does happen in real time. You can adjudicate usually online by an NDC, so you can see we have that process in pink. The medical benefit, unfortunately, is a pretty inconsistent process, and it's usually the billing codes are done by a HCPCS code. As we move down the process flow, you'll see that we have, is a prior authorization required? And if yes, that again is a process they can do electronically through EPA. And then we have the REMS program. So a lot of these specialty medications are regulated by the FDA and do have a REMS program. And we'll get to that process in just a little bit. And as we're finishing up, you can see we still have a financial and copay assistance program. So a lot of these medications are going to be high cost, high deductible, high copays. So really being able to provide assistance for these patients to help with the burden of that copay so they're actually able to fill the medication and begin therapy and pay for it. And then the last couple steps are the clinical counseling. So letting the patient know about the side effects, how important adherence is going to be for these therapies, and then also any administration that they may need to do with this medication. And then we finish with the scheduling and the shipping of the medication. So this we've kind of have classified as the process flows that are needed to dispense on the specialty pharmacy. Next slide, please. This slide here then highlights on the prior authorization side. And like I mentioned, for the medical benefit, we're a little bit behind. It is an inconsistent process. It is more manual and fax-based. So a lot of picking up the phone and calling, doing the benefit verification process, where you can see on the pharmacy benefit, they can run a test claim in real time. The electronic prior authorization can be done electronically too. And that flow seems to be going a little bit faster than if it is going under the medical benefit. Next slide, please. And then we have the REMS process flow here. So you can see there's a lot of data going back and forth that needs to be captured and communicated to all these key stakeholders. These process flows vary a lot depending on the medication and the program that is associated with it. It can be an action as simple as educating a patient on the initial therapy, the warning signs prior to dispensing and prescribing this medication, so providing them a package insert, or it can be where you need to verify a negative pregnancy test prior to each dispensing of the medication. So there needs to be a confirmation that this pharmacy is authorized, a confirmation that the lab test results have been done, an authorization that you can dispense the medication, and there is a do not dispense date, and obviously the exchange of the NDC, the quantities, the day supply. The reason we are creating these process flows that I've shown you today is to ensure as we're working on strategies and next steps that all stakeholders are talking about the same process, and if we're missing any important process, we can go back and update. And also to make sure that this work group is focusing on the right priorities. In a couple minutes, Laura will be talking to you about a survey. And I encourage all of you to provide feedback and take time on the survey. They'll discuss these process, the process flows that I've just shown you, and also help us set priorities. That way we're working on the right things to be successful in helping our patients. So it will be very impactful for you to go through, to fill out this survey and also help us move forward on the right direction. So, and with that, I'm going to turn it actually over to Laura now to discuss the current transactions impacting the specialty process.
Thank you, Julie, and good afternoon, everybody. We can go ahead and move to the next slide, please, Brian. So I'm going to talk a little bit about ePrescribing. We'll start there. Many of you are familiar with the script standard, which is the nationally named standard for electronic prescribing. In the current version that is being used, which is version 10.6, there are a number of elements that were identified by specialty pharmacies several years ago that said, oh my goodness, if I could just get this information on a prescription, it would make my life so much better. And those elements were diagnosis, the height and weight of the patient, and insurance information. And those are all currently available. So about 3 years ago, we published additional guidance recommending that these fields be populated when a prescription was being sent to a specialty pharmacy. Retail would like them as well, but they don't have the same level of need as the specialty pharmacies do for some of these bits of information. In the next named version, which is version 2017-071, we added a number of elements. A task group met for months, probably 18 months, to come up with these elements that were needed. And so we added things around e-prescribing of specialty medications, agency and service information, so that the prescriber could indicate that nursing services were needed or infusion services would be needed in the patient's home. We added elements to support IV administration, including titration and specifics around the IV itself. We also added patient information, such as hospice status and alternate contact information, so that caregiver information could be communicated to the pharmacy, especially important for pediatric patients, so that the pharmacy would know information about the parents or the guardian. In addition to those components, we added clinical information specific to wound care to support appropriate dosing. There is enhanced e-prescribing of compounded medications that will be available in this next version, as well as details surrounding allergy and adverse events and substance use. So that field has been expanded into a segment to support frequency of use, quantity, and levels. So all of that has been added to this next named version. And the industry is in the midst of moving to that version for 1/1/2020. So I would encourage all of you to make sure that your implementation plan is leveraging those elements that will benefit specialty e-prescribing. Next slide, please. Okay, electronic prior authorization. Julie touched on this a little bit in her process flow, and we do have transactions that are available and being used in the industry today. They are within the script standard, and they were first published in July of 2013. These transactions use a request and response model, and they support both prospective and retrospective. So if the physician knows at the point of prescribing that the medication requires a prior authorization, and they may know that just based on their practice, they can go ahead and request that before the script is sent to the pharmacy. If for some reason they don't do that or they don't know, the retrospective model allows for the pharmacy to communicate that to the physician so that the physician can go ahead and request that prior authorization. There are also cancel and appeal functions available within the transactions. The one other thing that the standard does support that has not been widely adopted yet is pharmacist-initiated requests. And you may need trading partner agreements to determine if that is applicable for your practice. So a specialty pharmacy may want to reach out to their payers and say, hey, will you take a prior authorization request from us? And see if they can help expedite that process to improve patient speed to treatment. Enhancements continue to be brought forth by the industry. A lot of guidance has been published in the NCPDP script implementation recommendations document, which is available on the NCPDP website under our resources link. And then I would be remiss if I didn't point out language that was included in the recent HR 6 bill. Some of you may be aware that there was a significant package of opioid-related bills that recently passed the Senate and is now on its way to the President's desk for signature. Among that bill is a section about electronic prior authorization for covered Part D drugs. You can see the language on the screen. The provision requires the Secretary of Health and Human Services to establish a standard secure electronic PA system no later than 1/1/2021. We are anticipating that we will see a notice of proposed rulemaking from the Secretary. that will likely name the NCPDP transactions as that standard system. So fingers crossed, that's what the industry has been waiting for and working for. And so I just wanted to make sure to point that out to everybody. Next slide, please. So if we talk about REMS, again, Julie mentioned this with her flow, and everybody's well aware of the complexity of the exchange of information there. So the first implementation guide for REMS in our claims standard was introduced in 2011. The telecom standard is what is used to process claims. The change that was made allows pharmacies to electronically confirm that the REMS requirement has been met and the pharmacy can dispense the medication. While in relatively current legislation, this standard is not named. The transaction has been implemented by pharmacies and intermediaries through trading partner agreements. As of earlier this year, the standard is now being named under the Medicare Modernization Act. We have made changes within script to support that, to allow REMS administrators to present prescribers with a set of questions similar to how EPA functions, which is the prescriber knows that it's a REMS product, they say they want to prescribe it, the REMS administrator will come back with a set of questions to say, please answer these questions, and depending on the answers, then the prescriber is authorized to go ahead and write for that medication. So you can see a sample of that on the screen for your transmucosal immediate release fentanyl products or your TERF products. And it's a simple question answer, and then there's an agreement form that gets signed. There are current task group efforts focusing on review of FDA guidance documents and identifying gaps in that document, as well as looking at additional use cases. So again, another opportunity where there's an electronic transaction available to support activity around specialty prescribing and dispensing. Next slide, please. All right, real-time prescription benefit check. This is a very hot topic in the industry. It is something that is being watched at various levels of government, and this is a way for primarily for the prescriber to know at the time of prescribing if the medication and the pharmacy that has been selected are covered under the patient's benefit. So NCPDP is currently working on creating a standard for this. It will be 2 formats or 2 syntaxes, EDI and XML, and then there will be 1 implementation guide. And this will support the exchange of this data between providers, whether prescriber or pharmacist, and the processors. Similar to prior authorization and REMS, it is a request and response model. So the prescriber has made their product selection, the patient has identified the pharmacy that they wish to receive the medication at, and the transaction is sent off, and the response establishes patient eligibility, product coverage, and benefit financials, as well as any coverage restrictions, alternative products, or benefit alternatives that may exist. So I will point out that there is a webinar next week on October 9th at noon Eastern. So on that same ncpdp.org site where you registered for today's webinar, you can also register for that to learn more about this. But this task group has been working for several years to build out this standard. There are at least a dozen use cases that were identified, and work is progressing. So while there are proprietary solutions in the marketplace, we know that there is a need for an industry standard, and we are working hard to bring that forward. Next slide, please. On specialty pharmacy reporting and data exchange, this was a task group that was really looking at reporting to support contractual arrangements between the manufacturer and the specialty pharmacy. The group had originally identified 4 categories: dispense, patient census in the aggregate, performance metrics and case management, and inventory. In January of this year, we did publish the dispense report standard, which is available for use. And in a couple of minutes, I will talk about what the task group is working on currently. Next slide, please. So now we'll talk a little bit about the brand new specialty work group. So if you can move to the next slide, please. So the goal really was to create a central way to address specialty issues and help members identify where to go to find updates and get information from specialty. As you can tell, a lot of work around specialty has been occurring for several years. But what we heard from the industry was it wasn't centralized, it wasn't coordinated, and it wasn't an efficient way for them to come in and participate and get the information that they needed. So in May of this year, we formed this work group. Our first meeting was held in August, and we really wanted to focus on better visibility around specialty. Where are the opportunities to improve the manual workflow processes that Julie discussed? And even the existing electronic processes. We know that they're not perfect for specialty, so where can we enhance those? Obviously, the patient journey, that's at the core of everything that's being done, is how do we improve this for the patient? How do we initiate therapy and improve speed to therapy for the patient? And then how do we look at reporting and metrics and improve that data exchange for the stakeholders? So we met in August. Our next meeting is November 9th in Charlotte. So if that's not already on your calendars, we'd encourage you to join us and participate. Next slide, please. This again talks about the survey that Julie mentioned and includes the link. So we would encourage everybody to participate and give us your feedback. Julie, Pooja, and I are not the specialty pharmacy experts. That is many of you that are on this call who are in this, living this every single day. So we need your help in identifying what the issues are and how to prioritize the efforts of the work group and the task groups. Next slide, please. So the Pharmacy Data Exchange Task Group, I talked briefly about this. Their original focus was on the pharmacy to manufacturer data exchange, and that's partly because of the work group that they used to reside in. We've now moved this task group into work group 18, and we know that there are additional use cases that are being identified. We met earlier this week to look at things such as outcomes data, and so we expect that the scope will be revised to include stakeholders other than pharmacies and manufacturers. Our next meeting is November 14th, and I am co-leading that along with Brian Odegaard from Endion Consulting. Next slide, please. Specialty requirements for ePrescribing. This is a task group that was originally formed in 2014 and until recently resided in our ePrescribing work group, which is work group 11. I talked about a number of the changes that were made to the script standard that were brought forward by this task group. The current focus is really on the enrollment transaction. So taking that enrollment information and being able to move it independently of the prescription among prescribers, pharmacies, hubs, or other stakeholders that might need that information, such as an infusion center. So this is information that's provided generally by the prescriber or their delegate. It includes demographic and clinical information, order-specific clinical information, and instructions related to the delivery of the medication. And this will likely be added either to the script standard or our specialized standard transaction. We're still working through all of that. That group meets again next week, and Michelle Kidd from Accredo and Maggie Buckinger from SureScripts are leading that. So those were two of our existing task groups that have been moved into work group 18. And I'm now going to turn it back over to Pooja to talk about some of our newer task groups.
Great, thanks, Laura. So as Julie mentioned earlier in the presentation, one of the most difficult roadblocks of e-prescribing specialty medications It's determining whether or not the prescription is covered under the pharmacy versus the medical benefit. So if the drug is covered under the medical benefit, all of the transactions that Laura spoke about earlier, including real-time benefit check, EPA, and REMS, are not usable transactions at this point. Today, there's really no single source of information that's being presented to the physician to indicate if the drug is covered under the pharmacy or the medical benefit. And this was one of the issues that was identified during the first meeting of the Work Group 18 back in August. So we created a new task group to focus on this topic. So it's a benefit coverage identification task group. It's being co-led by one of my colleagues at Point of Care Partners, Jocelyn Keegan, and Jason Reed from CenterX. And they actually have their first meeting October 22nd. And we encourage, again, those of you that are on the call that live and breathe this every day to get involved, because this is really one of the key pieces that needs to be identified in order for us to be able to move forward on being able to standardize and automate some of these processes. Let's move to the next slide, Brian. And the second task group that was formed that came out of the work group was the Stakeholder Outreach and Education Task Group. As I mentioned earlier, one of the goals of NCPDP is to make sure that the parties and the organizations that know this space and are involved with these medications and the business around them to start getting involved. And what this task group is, goal is to actually reach out to those that may not know about NCPDP, may not know that this new work group has formed, and really try to get those folks involved and make sure, as Laura mentioned, we're not the experts around this, you guys are. So we're really looking to get that participation in these task groups and work groups to make sure that what we're developing in terms of standards will meet your needs. The co-leads for this is Lisa Klein from CoverMyMeds and Michelle Wong from PharMedica. Their next meeting is Wednesday, October 17th. And again, we encourage you to get involved. So on that note, let's move on to the next slide and talk about how you can get involved with some of these task groups. Go ahead and flip to the next slide. So in order to join a task group, these task group meets via conference calls, and it always happens between the quarterly work group meetings. On the slide that's on your screen right now, you'll see a link to the NCPDP Collaborative Workspace. If you have an account, you can go ahead and get logged in. And if you don't have an account, there will be a link that allows you to get signed up and get registered. Now, this is actually free to anyone in the industry, so you don't have to be a member of NCPDP to be part of a task group, but you do have to be a member to vote on any of the items that may come out of the task groups that are presented at the work group meetings. But to get involved with the task group, to hear what's going on, to provide your input into the standards, you can participate in these task group meetings. And again, you'll have this information. So when you click on the link, it'll walk you through how to get registered for that. The other great resource for those that are looking to get involved is our staff liaisons. And if we go to the next slide, actually, I think there's one more slide in between that. So real quickly, just when you do get involved, when you sign up for the Collaborative Workspace, there's information that's out on the Collaborative Workspace that has the task group calendar as well as announcements. And so you'll be able to see, you'll be able to get signed up, and you can actually get reminders in your email about upcoming meetings. So it's a great way to make sure that you know what's happening and start getting involved with these task group meetings. Let's go ahead and move to the next slide. So we, as the co-chairs of Work Group 18, are blessed to have some great NCPDP staff that support our work group as well as all the task groups, and that is Terry Fortin and Paul Wilson. These folks really support the task groups as well as the work group co-chairs and co-leads, as well as the members for NCPDP. So these two staff members can also help answer questions as you're going along, and if you run into any issues trying to sign up for either the collaborative workspace or one of the task groups, they're always there to support you. All right, let's go ahead and move to the next slide. So in addition to the task groups that meet, they usually meet either on a weekly or bi-weekly basis. We also have quarterly work group meetings, and so the main work actually gets done in those task group meetings, and then those task groups will bring to the quarterly work group meetings all of the work that they've done. And it may be that there is a standard, there's additional elements that need to be added to the standard. There could be some a new task group that wants to be developed. So all of those decisions and ballots or voting happens at these work group meetings. And as Laura mentioned, the next work group meeting is actually in November in Charlotte. And as we mentioned, they're actually on a quarterly basis. So you can see in February, we're going to be in San Antonio, and then in August in Philadelphia. And again, you can go to the NCPDP website where you signed up for this webinar to learn more information on how to become a member of NCPDP, and then also how to attend one of these work group meetings. Go ahead to the next slide. In addition to the work group meeting coming up in November, we did mention that the new script version has been mandated, and NCPDP is also offering an educational summit on that new script version. So as Laura had mentioned, there were several fields that were added into the new script version that could help support e-prescribing for specialty medications. So if you'd like to learn more about that script version and the implementation, there's actually the educational summit in November is going to be focused on that new version of script. And again, we've got information on how to get signed up for that. Next slide. And then finally, NCPDP does do an annual conference in May, actually out here in Arizona. The weather is still pretty decent at that time, but it's an annual meeting of the membership. There's always some opportunities to network, and there's some great sessions that are always available for those that are in the industry. You get exposure to emerging technologies and industry leaders. There's some great events as well, so that information is also available on the main NCPDP website. Next slide. All right, so that is our presentation. I'm going to quickly run through these post-test questions and answers, and then we'll go ahead and just as a reminder, if you have any questions at all, please go ahead at this time and type those into the chat box so we can answer any questions that you may have. So let's go ahead and run through the post-test questions. So the first one is, what is NCPDP? And you can see the answers, potential answers. Let's go ahead to the answer screen. So NCPDP is the ANSI accredited standards development organization focused on healthcare and pharmacy business solutions. Go ahead to post-test question number 2. So what are some of the gaps in the specialty medication-related patient journey? The answers are, where do I fill my medication? Can I afford this medication? How do I administer this medication? Or all of the above? Let's go ahead to the answer. And it is all of the above. Again, you know, the main goal out of this work group and all the work that we're trying to get done in the task groups is really to improve on this patient journey for those patients that are prescribed a specialty medication. So really all of the above in terms of the gaps that we're seeing today And the final question, what are the existing NCPDP transactions currently impacting the specialty process, script, REMS, EPA, or all of the above? Let's go ahead to the answer. And that is all of the above. So all of those transactions are existing transactions today that are available to members of NCPDP. You can get all of the technical documentation if you become a member and download all those, the documentation for these existing transactions. And we do actually have one more post-test question, actually two more. Let's get through those and then we'll open it up for questions. So question number 4, what is the goal of the benefit identification task group? Identification of pharmacy benefits, address the areas of opportunity related to determining if coverage is through medical or pharmacy benefit, or building a benefit transaction. Let's go ahead to the answer on that one. And that would be B, determining whether or not the medication is covered through the medical or pharmacy benefit. And then our last question, how can you get involved? Become a member, join a task group, attend a quarterly work group meeting, or all of the above? Let's go ahead to that answer. And that is all of the above. And again, you will have, if you go to the NCPDP website, you can find all of the information on all of these potential ways to get involved. All right, Brian, I am going to now turn the call back over to you to get us to the questions.
Thanks. We'll now start the Q&A portion of our webinar. Remember, you can ask a question by typing in the question pane and you go to webinar toolbar. We did have multiple people ask if the slide deck was going to be available after this, and yes, I will be sending that out as soon as I can after we are done here. Laura, would you like to address the first question?
Sure. Do you want to go ahead and read it for everybody, please, Brian?
Yeah. Is there any way to break up the contracts for specialty that all pharmacies can fill these medications, or at least make progress that the patient can fill at a pharmacy of choice?
And that is a great question. I think the work that's being done from a standards perspective is to ensure that the patient and the prescriber are aware of the financial implications of their pharmacy selection. So through changes to one of our other standards that we didn't address, the formulary and benefit standard, as well as to the work that's being done on the real-time benefit inquiry, trying to make sure that the patient knows that if they select pharmacy A, there may or may not be a cost differential that they need to consider as opposed to another pharmacy. Beyond that, I think we start getting into areas of antitrust, and NCPDP adheres very strictly to their antitrust policy. And some of those discussions are simply outside the realm of what we can do from a standard solution. Other questions that have come in?
Yeah. An example was shared in which a patient waited 7 months from diagnosis to receiving their medication. Is there one or two particular components in the process flow that has been identified and as contributing significantly to such delays?
So I'll go ahead and take that one because I was actually at the conference where the patient shared that. And it was, I think there were a couple of factors. One was the prior authorization process, and part of it was getting the physician engaged to do that prior auth, which was a manual process. I think the other part of it was in that financial assistance step. Oftentimes when you're dealing with a needs-based solution, it takes a significant amount of time sometimes for patients to pull together all of their financial documentation that's necessary to submit those applications. So I don't think there was any one factor at play. I think there were several factors at play that led to that delay.
All right, our next question. Does the working group have an idea of who would own real-time benefit benefits investigation, provider, provider assistant, pharmacy liaison or navigator in a clinic or pharmacy.
Julie, you want to take that one?
Let me just make sure I understand the question. Is the question of who is responsible and sharing that information with the patient, or who's responsible for actually like running the transaction? Does that make sense?
It's not clear. It just says, running the transaction.
So I think the goal, and Pooja and Laura, please add additional, is really to have some transparency at the time of prescribing the medication so that the patient has visibility with this could be your copay, this may need a prior authorization, that way they know up front what kind of potential delays and financial obligations this medication will have. So really working in, if it is e-prescribed, working in that EHR, that way they have visibility there up front at the beginning of the process. Pooja, Laura, would you guys add anything additional to that?
Yeah, no, this is Pooja, and I agree with that. I think, especially with the real-time transaction, the goal is to try to get that information during, while the physician is actually doing that prescribing. But of course, that could always lead to a prior authorization. And when the prior authorization starts, that's usually passed along to a staff member or a nurse or someone else to actually kind of kick off that process. So, but the real time specifically is, the goal is to have that prescriber, that transaction run prior to sending the prescription to the pharmacy. So it's most likely going to be the prescriber that's doing that.
And I think, this is Laura, part of the implementation decision would be, is that something that is a manual step for the prescriber, or is that something that's, or even the pharmacy, if it's the pharmacy doing it, or is that something that's automated within workflow?
Yep.
Correct.
So, a lot of people in the proprietary implementations are automating that step so that it simply happens, and then the review information is presented to the submitter. Other questions, Brian?
That's great. Brian, can you check if that answered the question they were asking?
Yeah, it did.
Okay, thank you.
Our next question, RTPBC provides a mechanism for presenting the prescriber with alternative therapies. How are those alternative therapies selected?
So that is a decision made by the processor, the PBM, or the plan based on their formulary information. So they might have a product that has a more preferred formulary status. It could be a generic alternative, but that is a decision made within the plan. And then the standard simply supports the exchange of that information back to display it for the provider.
All right, our next question is additional clinical information required for specialty processing, for example, labs, therapy history, etc., in scope for specialty NCPDP changes?
This is Laura. I'll take a pass at that. That's a great question. We do support the exchange of some clinical information within the script standard today. I talked about height and weight. There are also some lab values that can be exchanged. The enrollment transaction that is being worked on also supports, or will look to support, additional clinical information. I will say, under the heading of if you build it, maybe they will come, several years ago, NCPDP created a clinical health information exchange request and response set of transactions that are available to support exactly that, the exchange of that clinical information. Unfortunately, we've not seen widespread adoption of that transaction, so we are looking at other ways to support that.
And I would just say, if there's any other use cases like that, that's definitely something that this work group would like to hear, like what other additional data elements are not in an electronic format that we need to build out in the standard.
All right, our next question. When and how can PMS vendors begin testing script 2017071 transactions?
Great question. I think it's Brian, probably you guys, but I think the testing tool is actually available to, now, isn't it? I think on.
I believe the testing tool is available, and I believe the SNP committee, the Strategic National Implementation Process Committee, has published a timeline for script testing. I know an update on that will be presented at the Educational Summit in Charlotte, and it may be available on the SNP page on the NCPDP Collaborative.
Yeah, and the testing tool for 2017071 is up and running, and we'll send out information on that along with the slides.
Thanks, Brian.
Yep.
All right, if there are no more questions, that concludes today's webinar, Specialty Pharmacy Overview. I'd like to thank our speakers today for their time and expertise, and thank you all for your participation. Have a great day.
Thank you.
Thank you, everyone.
Bye-bye.